today's topic, groin. Why I chose when Dr. Gagan asked me, would you like to speak and what would be the topic, is because groin, I flounder, and till date, I find it one of the most complex sports injuries to treat. And it's complex because, why is it complex? Because we don't actually have a definition. We really don't know exactly how to call what a groin. And there is a muscle involved, there is a skeletal, the bone involved, there's a nerve involved. So it's a quite a complex injury, and all around a small area of the pubic symphysis. Mechanism of action of this injury is generally common in all the cases. Symptoms also are generally common in all the cases. So it is quite challenging, and I'm sure all of you would have come across groin pains, and it is quite a challenge. And one of the other four reasons which I put is the anatomy is complex. There are multiple pathologies which coexist. For example, there'll not only be an adductor, there'll be an iliopsoas involved. The injury causation is multifactorial. We will see it gradually in a presentation. What do I mean by multifactorial? And there is no actual evidence-based medicine regarding the diagnosis and management of groin. There is hardly anything. They're all very broadly discussed, and it's each one to himself. I might think of doing something my way. So the idea of this presentation was, I attended a groin conference which was organized by Aspetar way back in 2015 or 16. I got a lot of input, so I read a lot about groin then. Then I did a little bit of researching. So my talk today is going to be centered around all this information which I have gathered, and I hope it helps all of us in treating cases. Groin pain, surprisingly, it ranks only behind the knee and ACL and fractures. Yet it's quite a neglected field in terms of information. So literature says 5 to 18% of all athletic injuries, and 1 in 3 footballers will definitely suffer from a groin pain. So when this was put across in 2015 to the, I attended this in 2016. So 2015, there was a groin conference in Doha. And what they did was they initially sent out two clinical cases to 26 different sports medicine physicians, orthopedic surgeons, physiotherapists, various sports scientists. And from those two clinical cases which they sent out, asking them what would be your diagnosis, for each case they got about 23 different diagnoses. So that's what happened. So we don't really have a consensus. So then they came out with this Doha agreement, and they defined clinical entities which are purely the groin, which we want to talk about, and two other which are hip related or others. Hip related could be a femoral acetabular impingement, a pure hip, or a labral tear in the hip, or those hip related, or others could be an actual inguinal hernia. Those are different. So when we talk about the defined clinical entities, we will be centered around adductor related, iliopsoas related, inguinal related, and pubic related. So this is a very beautiful picture I found, and I think most of you must have also seen it. This is a pelvic clock. Helps us identify where exactly you would have injuries. And this clock would be like, if your clock is placed here at the 3 o'clock position, you have between the 2 to say the 4 o'clock, you have the pubic symphysis. The 6 o'clock position, you have the adductor longus. At the 9 o'clock, you would have, around the 9, you would have the inguinal ligament. Above at the 12, on the right of the 12 would be the rectus abdominis, and on the left would be the superficial inguinal ring. How would this pelvic clock make sense to me? I would use the pelvic clock to understand the surface anatomy of localizing an injury during examination. A quick recap on the functional anatomy. We have, when we talk about the groin, we should focus our attention around the adductor tendinopathy, which is the commonest. The attachment on it, that's the pubic bone. We have the iliopsoas. We have the conjoint tendon, which is made up of your internal oblique and transversalis, the fascia, which can be injured, and then we have the rectus abdominis coming on to the pubic symphysis. Now, the functional anatomy is important to understand because the sportsman hernia and your obturator nerve, or the neuralgic areas, are around the common places of the pubic region. So we need to know, as we delve further into the talk, I will discuss a little more about the hernia and the nerve entrapments. So what is our differential diagnosis? So my methodology of this talk is slightly different, because I understand we all are clinicians and we all come with a lot of information and knowledge. So I'm going to back and forth to not go in the standard pattern of how things are taught, or because I don't expect to be teaching you, but to discuss a lot of information which I have gathered through whatever little bit of reading and a little bit of experience that I have. So whenever we talk about a groin pain, we talk about a groin disruption, a broad-based diagnosis, which I don't really like, called athletic pubalgia. I don't like it much, because athletic pubalgia is like a waste paper basket. You throw anything around the groin into it. Whereas we should try to be a little bit more specific. So what are our DDs? We have the muscular tendinous, which is the adductor. Then we have a nerve entrapment, which, sorry, is the obturator ilioinguinal nerve. Then we could have the inguinal canal, and then we have the pubic bone. So like I said, we have a muscle, we have a nerve, we have an inguinal canal, and we have the pubic bone, the osteitis pubis. So we have 4 DDs when we are discussing it. So another very beautiful picture to visualize your injuries is if you draw up a line from the ASIS, the anterior superior iliac spine, to the pubic tubercle and to the midpoint of your rectus femoris, like a triangle. So any injury within it broadly would be a iliopsoas. Medial to it would be your adductor. Lateral to it would be more of your hip joint pathologies, like your femoral acetabular impingement, OAs, or labral tears. And superior would be your rectus abdominis, inguinal canal pathologies. So commonly, if medial to the triangle would be adductor related bone and stress injuries, lateral, like I said, hip. Superior would be abdominal wall, rectus abdominis, conjoint tendon, external oblique hernia, and within it would be the iliopsoas related. Not going to go into the less common and not to be missed. So let's see a case study. 21-year-old male plays college competitive level football with persistent groin pain presented at the clinic. Athlete was completely recreational, had symptoms of groin pain in the region of the groin. So, findings. The patient described his pain as localized to one specific region in the proximal portion of his left groin. See the things which I've highlighted. Palpatory pinpoint tenderness was elicited at the proximal portion of the left groin at the tendinous insertion. A physical examination revealed pain and weakness of isometric adduction of the hip muscles. Clinical diagnosis: adductor tendinopathy from repeated microtrauma, and overuse was suspected. MR imaging was taken to confirm the diagnosis. Pretty straightforward, pretty simple. I wouldn't go in for the MRI immediately. I'm not a great fan of over-investigating athletes. I would rather go in for a musculoskeletal ultrasound, but nevertheless. So 40% of all your groin pains, generally the maximum groin pains, they say, are because of adductor, which could be an acute or chronic tendinopathy. So the adductors act as important stabilizers of the hip joint, and we know it's a great flexor with the hip and extension. So it can be acute or it can be chronic. Generally, acute are on the muscle tendon belly, and chronic are at the pubic tubercle. Generally, that is what is the teaching. So accurate clinical assessment is in choosing the correct treatment. Acute strain could be in the myotendinous junction and maybe at the proximal enthesis. What are the symptoms? You feel a pull in the muscle with sudden pain and worsens as the athlete cools down. Acute adductor strain. So acute strain, if it is a tenoperiosteal attachment. Now, this is very important. If it is a tenoperiosteal, do not start stretching it immediately. We generally feel any strain or any pull, so-called. We want to stretch out that muscle. So if it is at the tenoperiosteal, be rested until pain and local tenderness has settled, and with gentle stretching and strengthening to follow a period of weeks. That rehab program we'll discuss a little bit. And if it is at the myotendinous junction, it can be managed more aggressively, provided bleeding has stopped, and you know that you're not going to get a myositis ossificans. Chronic adductor related. Now, this is where we all get a little flabbergasted, and I get a little shaky. Is when generally the people who land up with us are chronic adductor related injuries. They do not really recall an acute pull. The onset is insidious. Pain and stiffness in the groin region in the morning, gets better with warming up. So gives a sense to the athlete that I'm okay, and it doesn't stop activity. It's there at the beginning of the athletic activity, and typically the patient says that I get up in the morning with pain, but as I warm up and I start playing, my pain reduces and I'm good to go. But as soon as I stop, it's back, and in the morning I get up with severe pain. So there are 6-7 signs which most of us will observe. Bruising on the medial side of the thigh is common. Tender swelling or palpable defect. Pain on passive hip abduction. Pain on resisted adduction. Tenderness at the origin of the adductors. Groin pain on resisted hip abduction. And groin pain on isometric adduction. But now I want to share some very nice thing which I realized, that the current signs of evidence-based for an adductor related injury which says that your athlete currently is not fit to play and has adductor related groin pain is 3. 1, pain and the strength of your adductor squeeze test. Second is a reduced hip internal rotation, and third is a bent knee fallout test. I'll show you a picture of it. So if your coach comes and asks you, boss, is this guy ready? Does he still have, or do you think he's still suffering from a groin pain which is going to affect his game? These are the 3 things which will help you identify that this adductor groin pain is still on. And if the same coach also tells you that I have this guy, what do you think? Is he ready for the season or not? So you must remember the future risk of a groin injury is 2.5 times more at risk if he has had a previous one. If you have a reduced adductor strength, generally the adductor should be 1.2 times more than the abductors. So you have to, so generally abroad they use a dynamometer to check the adductor and abductor. If we do it objectively, we can subjectively see, compare the 2 sides to see if your adductors are similar on both the sides. And third is a reduced range of motion. So the upper one, the current science and evidence based, they tell you about the current situation, and the lower one, that is previous groin injuries, reduced adductor strength and reduced ROM, is for the any chances or a kind of a screening for the future if you're taking an athlete. Investigations in adductor related groin pain, ultrasound is the investigation of choice. However, if you're not getting it, and MSK US, as you all understand, is pretty specific, is pretty complex. Very few people who are very good in doing it. You can go in for an MRI. So these are the pictures of adductor related groin pain testing. So you can roll your finger in the around the area of right from the pubic tubercle, you'll get the pain here, which can travel 7 to 17 centimeters. This is one. This is the bent knee fallout test. You could do the isometric adduction test, which I like doing it with the knees extended rather than the knees bent, because I feel I can isolate the adductor still better. So this is the way I would do an isometric adduction test. This is showing us an the internal rotation and an external rotation, how to check. So I'm sure we all are familiar with it. This slide was just a quick recap to show you how to palpate, where to look, how to do a adduction, in internal rotation, and a bent knee fallout. So we do have the iliopsoas also, and uh, isolated iliopsoas, the literature says, is uncommon, and generally it would present along with a adductor or a hip related groin pain. And it also shows that the iliacus for some reason is more, at times more injured than the psoas, but we need to know if we have a concurrent iliopsoas injury so that we can work on that too. So like we know, the psoas is D12 to L3, and the iliacus from the ilium right into all of them then get inserted into the lesser tubercle and a good hip flexor. So in this slide, we say, in this picture, we see how to palpate a psoas. So what you do is go along the lateral border of the femur, dig down a little deep, and tell him to do a straight leg raise, just a straight leg raise. You can feel the psoas tendon roll under your fingers, and if you go down and tell him to put it as a like a Faber and identify the sartorius and go medial to it, you'll again get the tendon. The tests are the Thomas test, where you put him at the edge of the bed and then take the one knee towards the chest and then extend the other to see the tightness. You also get sometimes you get confounded because the rectus femoris might also present with tightness. But this test also will give you a pain in the iliopsoas if present. And this is one of the pictures of with the hip at 90 and the knee at 90. He's trying to flex the hip, and you pull it towards yourself, which gives you an idea of the isometric strength of the hip flexor. I'm showing you this one. This is a good test for knowing the strength of the iliopsoas, and it's a very important test. Your iliopsoas strength in good, strong athletes they'll pull your arm right across to you. And when you do it on the injured side, if the iliopsoas is injured, you can easily pull their knee away from them. So this is one of the tests which we do. The other thing which I would want to talk to you about is there is a very well established protocol. I don't know if most of you are familiar. I got familiar of it when I attended these groin conferences and read further. There is something called as a Holmich Protocol, and I would urge all of you to read the Holmich Protocol, which consists of 2 modules. There's module 1, which is applied for the first 2 weeks. This is for your groin pain injuries, and then you have your module 2, which is from the 3rd week onwards, and they say it goes up to 18.5 weeks. And mostly this is in groin pain involving the adductors and the iliopsoas, but I have applied it in a mixed fashion for some other groin injuries also. And module 1, I'll just show you some pictures. So generally the rehab is focused around the core, the pelvis, the abdominals, strengthening the hips, legs, flexibility, and these are the exercises. So how do you potentiate rehab? Now, when we speak about rehab, I have a little bit of a problem with the way we handle cases, and I'm not trying to say that what others are doing is wrong, but we are too bound in doing things like physiotherapy and focused on treating and a tendon or a muscle using a lot of modalities. We are very, we are so overwhelmed by orthobiologics. We want to do PRPs, we want to do injections, we want to do all sorts of stuff, which are I feel are additional. They're additives. They are not the mainstay of treatment. Why am I conveying this? Is because I do see a lot of cases who have been through a round of various hospitals and doctors and physios and orthopedic surgeons and what all. And when they come to me and I ask them, what all have you done? They have done everything except for rehab. They've had umpteen ultrasounds, lasers, shockwave therapy, PRPs, but no one has worked on any of the, and isometric strengthening Holmich protocol can start from day one. It doesn't have to wait even for, and the teaching is the more the isometrics we do, that itself is supposed to reduce pain. So yes, it is good to use PRPs and I do shockwave therapies and things like that, where we have some kind of definitive injury, some disruption, some finding in that muscle, rather than just using a modality and wasting time. So that's one of the things which I wanted to convey to you all. And the active training program is things like this: static adduction. This is very simple. This is module 1. We can start off with severe groin related pain with a knee bend. Now, we can, if we don't have a pubic symphysis related or osteitis pubis or a rectus femoris, we can start off with abdominal sit-up straights. The Holmich protocol, obviously, like all of us know, all protocols are not, you don't have to be a lakir ka fakir that I will do this, I will do this, I will do this. You have to evaluate, see which patient suits what, and then go about doing it. It's like, I always say rehab is like cooking a dish. So you have to have some amount of everything in it. There is nothing like you will do it or you'll only do one part. It is like making a good dish. And something which I'm very, very fond of in all my rehab programs, and like I tell my physios who work with me, that even if he has a great toe injury or he has a hip injury, balance and proprioceptive is the thing which is going to get you results. So balance training is again in module 1, and balance training should be introduced as soon as possible. So this was module 1, and we must keep the besides the strengthening program, we must keep him fit in the other things as and when and how he is progressing, work on his other parts, and as well as work on his cardiovascular fitness, etc. There is another very beautiful thing. I think, I don't know if most of you know about it, but I went through the literature, and there is something called as a Copenhagen adductor strengthening. This is a excellent protocol to prevent groin injuries. So pre-season, it's there, you have to do it. It's more of a eccentric workout, and pre-season they recommend 3 sets, 6 reps 2 times a week and progressing to 15 reps. And during your training season, they tell them, they advise at least once a week you must do this adductor strengthening, eccentric adductor protocol. So there is not only an adductor. If you see, the upper one would be isometric contraction of the adductors, and the lower one would be an eccentric. So this is how they would do it to prevent it. Mostly in injuries which are involved in the groin pain, adductor related injuries, which are a lot of short stop, kicking, turning, twisting, those drills, those sports which are very likely, like for the footballers, this is part of the FIFA 11 program also, that they do this for preventing the adductor tendinopathies and the adductor injuries, which are 40% more common in footballers. Now we come to the case study 2, and here we have a 21-year-old male athlete who presents with a left groin pain that began gradually several weeks previously, but which has been progressively getting worse. Apparently, the pain is made worse with kicking type motions, hopping on the left foot, prolonged standing on either foot. Patient has a history of groin injuries on the left and a rectus abdominal muscle on the right. He underwent radiographic imaging of the hip and pelvis and MRI of both, which were negative. Now, when we get something like this, we are I would be very perturbed that MRIs are clear, no radio, there's an injury on the left, right, not aggravated by forced coughing. So these are the kind of things which fox you and you don't know what to do. So what is the examination revealed? An examination revealed an antalgic gait. Palpation revealed point tenderness over all these areas, symphysis fusic, inguinal canal, adductor tendon, but tenderness was more prominent at the pubis rather than the adductor. Passive and active range reveals pain on the left hip, abduction and external rotation. Strength testing was okay. Sensation and reflexes were intact. There was selective tension of left hip abduction or adduction is painful, and the resistive trunk flexion sit-ups was positive. There was a positive squeeze test, which you get in adductors also, and there was a positive Faber test in the left groin. What do we come to? So we had a point tenderness more at the pubis, which was more. We had a bend. We had a more or pain on a resistant flexion of the trunk. So we know this is more of not an adductor, but more around the pubic symphysis, and it is usually insidious and maybe felt unilaterally or bilaterally. Is generally a vague pain with stiffness of the adductors. You'll have a vague pain around the upper groin and stiffness of the adductors, which is an early warning of osteitis pubis. So vague pain associated with tightness, stiffness of the adductors during or after activity is an early warning of osteitis pubis. OP is advanced. The athlete often says they're unable to walk the morning after the game. So unlike a adductor where you can get up with stiffness and walk and warms up and gets better, osteitis pubis, he might have be unable to walk the next morning after a game. And the cardinal symptom is loss of power sprinting and long kicking. Secondary to pain inhibition is a cardinal symptom of osteitis pubis. So tenderness is a cardinal sign. Adductor muscle guarding is commonly present. Positive squeeze test, but that's confounding because it will be there in others. And a positive, a very good stress test is to do a passive extension of the hip, and that might reproduce a pain besides single leg squatting, but a passive hip extension. But if you have a crossover sign, that means you have the pain coming onto the other side. Also, that's a poor prognostic sign in osteitis pubis. So plain film, bone scans, MRIs, CT, controversial because of ionizing radiation. But I guess most of us are very happy doing MRIs, and dynamic ultrasound only if we feel. But in such cases, what I would do is I would first go in for more of a, I would rather go for an ultrasound and then go in for an MRI if I'm still not happy. And I will explain, or rather I'll let you know right now. I have a very simple system of doing work. I examine my patients every 2 weeks. Some might say it is over examining or not, but I always feel 2 weeks gives me a lot of time to cross correct. 2 weeks gives me time to see what is working, what is not working. It helps the athlete build confidence that he is being seen. And I urge you that 2 weeks is something which you should devote to spend. If not, what I do is that I go into the treatment room where the physio is working and have a 5-minute chat with the physio and the athlete. That itself gives me a lot of inputs on what is working. Like ask the therapist, what are you doing? Or what are the exercises? Where have we reached? Ask the patient how much pain. When do you get the pain? During the exercise, during the exercise, is it 0 to 4, 0 to 3? If you're there, it's okay. If you're recovering the next morning after an exercise session, it's okay. If not, what are the exercises? So keep doing these rather than examining a patient and straight away ordering an MRI. That would confound things. So wait on, do your examinations, begin with treatment, reevaluate them every 2 weeks. So this is where you would palpate for osteitis pubis, and this is what a radiograph of symphysis pubis demonstrating increased space between the symphysis would be seen. Now, no pain, osteitis will stop at onset of pain. So I would stop if the pain goes above 4 in the VAS scale. Facilitate abdominals, adductors as pubic symphysis stabilizers. So this is a concept of biomechanics, which I would discuss further on. Very important for us sports medicine physicians, people who are working in the field of sports medicine. Concept of biomechanics, concept of understanding an injury is very, very important. Pre-contraction of transversalis is essential. Regain effective muscle length without stressing the pubic symphysis. These are your muscle energy techniques. Will help you in regaining the muscle length, and the PNF stretches. All these come in. Maintain adequate fitness by cross training. A general rule of thumb is that longer the diagnosis is delayed, worse is the groin pain. And this is what we see in most of our cases. They come to us with long-standing groin injuries, and it's a struggle to rehabilitate them. So this is which I took from one of the publications. See, sufficient improvement in impairment, no concern, confirmed decision to run, no pain during run, negative squeeze test, increase the speed of test, doesn't have it, unload local tissue therapy. So have an algorithm of what you're going to do. So this is where your 2-week analysis, objective and subjective, helps you take a decision on how to go ahead. Third case, a case study 3. So we did a quick study of the adductors, the iliopsoas. We did an osteitis pubis, and now we see a case study 3 where we see a 19-year-old male track athlete. Insidious onset of lower abdominal soreness, 6 weeks prior after squatting, acute exacerbation a week prior during discus throw. He complains of pain, which is deep groin, lower abdominal curl-ups, and is relieved with over the pubic ramus at the insertion of the abdominis. There's pain around the pubic ramus at the insertion of the rectus abdominis and the conjoint tendon. Now, your palpation for tenderness is positive in the lower rectus abdominis local area. Your Ober test, for your IT band, your Thomas test for your iliopsoas, positive on both the sides. And you had a pain provocation test which was present at the hip adduction, and 90-degree flexion and 0-degree flexion, and pain provocation positive for resisted curl up bilaterally. So we know it is generally around the lower rectus abdominis area, but we did have tenderness along the inguinal border. So now comes one of the misnomers which most of us have started, most I would say, without understanding. Some people are using this term called a sportsman's hernia, which is a misnomer. What is sportsman area, or broader term uses athletic pubalgia, which I, as a very, I would say with very minimal experience or whatever, I call it a waste paper basket diagnosis, like we have the IDK, the internal derangement knee or OA knee. Giving diagnosis like this does not serve any purpose. For example, if you label someone as a OA knee, everyone you're going to examine after 45, 50 would have some amount of OA which is seen on the X-ray, and giving them a diagnosis that you put a OA does not make sense until you don't see the patellofemoral mechanics. You don't see which is the muscles. Why is this patient having pain? Do all OA have pain? So similarly, labeling someone as athletic pubalgia does not make sense, because this area has a lot of musculoskeletal injuries and musculus of the muscle and other soft tissues and bones in the pelvic area. So what we are looking at when we talk about a sportsman's hernia is welcome, Dr. Joy, sir. Good to see you. And see, the sports hernia is basically a weakness which we are seeing in the posterior wall of the inguinal canal, where we have the conjoint tendon, which is formed by the internal oblique and the transversalis fascia, which is inserting onto your rectus abdominis lateral border. Now, why I said twisting and repetitive injuries is your internal oblique is used for your trunk rotation and lateral flexion, and your transverse abdominis is your core stabilizer. So when you're having these kind of repetitive twisting and turning speeds, so which develop a risk of sports hernia, immediately you should catch on that this is something which is working on your internal oblique and your transversalis fascia, which causes a bulge, and this could mimic, and this is not a true hernia. This is not so if it is a actual inguinal hernia where you perform a invagination test in the scrotum and you have a bulge, that is a different entity. Like we saw in the Doha agreement, they come under others. That is not your that is not under your sports hernia. So sports hernia is basically your posterior wall of the inguinal canal, which you have an injury on the conjoint tendon and there's a bulge in the transversalis fascia. And as we all know that we have certain nerves which come in through that area, so you would have pain, tingling, numbness, so you might have a nerve entrapment also. So again, understanding, again I'm showing you the pictures of the functional anatomy which we discussed earlier. So we need to then talk about a little more about the symptoms. So you might have a unilateral insidious onset. One third may describe a sudden tearing sensation. Pain is typically localized to the conjoint tendon, but it may involve the inguinal canal laterally. Pain may be in the lower abdomen above the inguinal, or pain radiating to the adductor region or perineum with a concomitant osteitis pubis. Pain increases with sudden movements like acceleration, twisting, and all, like we saw in our athlete. So localized tenderness over the conjoint tendon exacerbated by resisted sit-ups, a dilated, tender dilated superficial inguinal range, which we can do by invaginating the scrotum. By definition, there is no clinically detectable hernia. So dynamic ultrasound is a modality of choice where you make him do a Valsalva's maneuver to look for the bulge. So a trial of conservative treatment, soft tissue mobilizations, do an examination, which we'll come to a little later, do dynamic exercise, focus on. So what did we talk about? We talked about internal oblique. We talked about transversus abdominis. So we know one is a core stabilizer. One we're talking about is a trunk rotation and lateral flexion. So let's work on those. Let's work on the tightness of other muscle groups after doing a proper examination. Then we can do sideline clamps with mini band resistance, side stepping with mini band resistance, step ups, additional exercises, single leg bridging, etc., etc. So generally, these are the cases where you should do a proper. So generally, professional sports people, they wait for 4 weeks if it is not. But the recommendation is 3 months of specialist groin pain rehab. If it doesn't work, then go in for surgery. I had the honor of meeting Dr. Muschavik. She's a German surgeon, and she was a a real treat to listen to her. So these are the three types of the surgeons who are doing, and I have sent two patients to Dr. Muschavik, where we just couldn't fix their pain, and fantastic results, back to play in 4 weeks. What she does is a very minimal incision, and fixes up the bulge in the transverse fascia, which is impinging on the afferent nerve, and fantastic results. So after a good for this patient whom I sent, I worked on him for about 10 weeks. We did all sorts of things. We did a lot of rehab, but it didn't get fixed. He would have troughs, and he'd get better, and then it would come back again. So greatly benefited. So there are other doctors like David Lloyd and Gary Gilmore who work on releasing the inguinal ligament, and Gary Gilmore works on repairing the 5 layers, and basically again all of them working on working on the posterior wall of the inguinal canal. So broadly, inguinal related groin pain, it's important to differentiate between inguinal pain and inguinal hernia. And inguinal related pain differentiate between nerve related and inguinal ligament tendinopathy, and the transverse facial bulge, which I told you. Pubic related, not very frequently in adults, but word of caution, important entity as an apophysitis in our young athletes. Remember, this is the last epiphysis to fuse. It fuses around 20 years of age. So you might have a traction apophysitis, very common. So so just jumping on and start stretching them instead of doing some amount of recruitment and synergy between the core stabilizers is going to worsen the case. And do not panic if you see that there is the epiphysis is out, because it does not fuse till 20 years of age. So an important entity, it is the last one of the last apophysis to fuse, and fuses around 20 years. It's commonly seen in endurance athletes and female athletes. I think one more last case, and then we'll go on to how we go about the examination. The reason why I am going about my presentation in this way is everyone gets very bored and tired when you go the way of what are the things. So I'm sort of making it a little interesting by giving some case descriptions. So a 21-year-old female athlete, so that should put you on guard. Progressively increased over last 3 months, runs 40 to 50 kilometers a week on various terrains. No previous history of groin hip pain, but there's some history of lower back pain, even though this is not present at the moment. Patient describes pain deep in the groin, which refers to the adductors. Claims pain on beginning running, but subsides on stopping. Mentions a band-like sensation around her thigh. Examination, lumbosacral spine SI were negative, ROM negative. Everything was fine. Pubis, slight apprehension. There was no perceived muscle weakness. Palpation was inconclusive for localized pain. So, female long distance runner with all these complaints, I feel your antennas should be up looking for some kind of a stress injury. So female long distance runner, pubic rami stress fractures are known. Following are the three features: activity causing severe groin pain standing on an unsupported leg, and exquisite, which was not there in this lady. We do go deep into the pubic ramus. So any kind of exquisite tenderness on deep palpation. But for me, my antennas are up when I have a long distance runner whom I do not get standard findings. After doing a thorough clinical examination, I would rather, hi Sunit, how are you? Great to see you. That the anyone with severe pain and induced by running, and like we know the grade 1, 2, 3, 4 related stress injuries, that is pain coming on activity goes off on rest, pain present at rest should give us an indication that we are looking at some kind of a stress injury in the bone. So gradual onset groin pain aggravated by exercise, night pain might be present in 20% of patients, may have pain and restricted occasional tenderness on deep palpation of the femoral neck. Investigation should include X-ray, bone scan. I would prefer these days we would straight away go for an MRI. So these stress fractures should not be ignored by a proper history. Training load history is very, very essential in such cases. And then the kind of pain, the vague symptoms, no proper clinical findings, you can always go in straight away for a MRI to be. So another group besides ladies is the young military recruits who would come in with this, and then we have to look for femoral neck stress fractures. I am not going broadly. So when I said we had the Doha agreement in 2015, we spoke about adductor, iliopsoas, pubic related, and inguinal canal, four things in the clinical entities which compromise the groin pain. The others were hip, which could be a femoral acetabular impingement, and others where there would be a proper inguinal hernia. So I'm not discussing phi because phi comes under basically a hip pathology. We are talking about groin pain, that is the musculoskeletal and the nerve tissue around the pubic symphysis region. Phi can mimic groin pains, but there are additional tests, and we have to be very, very, we should know that 40% of your adolescents who have taken part, it's sportsmen who have been training since adolescence in soccer, basketball, not ice hockey in India, they have a higher prevalence. I have seen it just last week in a army officer who's been trained, who was in a Sainik school and trained a lot. And he came to me and he said, look, I've got this cam impingement. Do I need surgery or I don't need surgery? And for God's sake, not all cam impingements need. 40% of all your footballers would have cam impingement. You have to look for symptoms. You've got to look for signs. You have to look for biomechanical, what is causing that pain, rather than just giving a recommendation for surgeries. I'm not against surgeries, but I feel that we should focus on more clinical examination rather than rushing into surgeries. Okay, clinical examination. So after talking about, so this talk of mine was a little different because I discussed cases before I came to doing, I should have done clinical and then gone to cases, but I just wanted to incite a little bit of interest. So this is not theory. You should do it. I know a lot of people who say that we've got too many patients, so I can't do all these things. But you should be able to at least see that this patient of mine or this athlete needs a proper examination because it's not getting better. And lower extremities, examine shoes, I do it. And examination should be done. What I do is I make them walk. I expose all the areas, see the alignment of their legs, see their arches, make them sit and examine, make them lie and examine, ask them, are they carrying their shoes? Very, very important source of information. So we look for all these things. I don't think I need to tell you, but very important. Do not simply jump into the groin and start feeling for the adductor and pubic symphysis. These are all contributory factors for an unstable pelvis, which will, in the long run, result in your groin pain. So look for pes planus, tibial torsion, genu varum, valgum, and then go on to see the bulk of your muscles, the arches, look for all these structures, make him walk, see the observation, make an observation on how he walks or runs, he or she. Now, this is an examination which I don't know if you all are doing, and those of you who are in Delhi and who wish to come and see me or meet me, this is one test which I've really fallen in love with. And people might say it's not very conclusive, it's not, it is subjective, a lot of variations, but I see a lot of I do a lot of this SI joint motion palpation. And believe you me that I have seen it in so many cases that you have a SI joint which does not move properly on one side, and just correcting it by certain simple techniques of SI joint mobilization fixes a lot of things. Not only in hip joint, any lower limb thing, you have to must do your Trendelberg, you must do your SI joint examination. You will solve. I tell my therapist, even if you have, sorry, just 1 minute. Even a great toe pain or an ankle pain, begin with an SI joint examination. Loading patterns come out beautifully if you see how your SI joint moves. Place your hand on the hip, thumbs on the PSIS, tell them to raise one leg and the other, and it should move in this manner. And if this one, like if you take the left hip up, then your left thumb should come down. And if you take the right left knee up, the left thumb comes down. And if you do the right, then the right should go up. And if it is not going up, it's going above, you know that there's a problem with the SI joint. I know SI joints are diarthrodal joints, they don't move by itself, but they move in relation with each other. You have your piriformis, you have your glute medius, they're all around there. Releasing them, mobilizing SI joint fixes a lot of lower limb issues. Range of motion testing, which I don't think we should, I think all of us should know how to do all these tests. Flexibility test, the Thomas test, very important, rectus femorals as well as the iliopsoas. Adductor flexibility, this is your bent knee test, your over test, again for your IT band. And certain cases, I do use a goniometer for me when I feel that this case I need to delve in a little more. Strength test, hip flexion. Weak hip adductor strength is a risk factor for groin injuries, like we discussed earlier. Hip adductor strength is reduced by groin injuries. Again, we discussed this earlier. And I said if we can use a dynamometer, we can do a strength. The adductors have to be 1.2. So I said if you don't have a dynamometer, do a eccentric test. I showed you some eccentric pictures. This is an eccentric test of the adductors and abductors. This gives you a lot of information where he lies on sideline, holds on to the bed, and then adducts and abducts. So you get a lot of information on both the sides. So you know. So in this illustration, he's using a dynamometer which is fixed around his arm. You can subjectively also know that if there's an injury, there will be a definite loss of adductor strength. This was testing your glute max, resisting a hip internal and external rotation. Strength testing. Iliopsoas can be strength tested like this, or lying supine, getting the hip at 90, the knee at 90, and pulling it inwards. You'll get to know if there is a real adductor related injury with iliopsoas. Very important in footballers. Now we come to a very important and one of my real favorite topics I like to talk about is the groin biomechanics. Now, when people ask us what is sports medicine, I've heard a lot of definitions of sports medicine, but one of the most nice definitions which I've read, what is a sports medicine specialist is, a sports medicine's goal is to maintain an equilibrium, a synergy between muscular skeletal system and your sport training technique patterns to avoid injuries and facilitate a superior performance. If you want to tell someone what makes you different in terms of musculoskeletal examination or treatment between you and an orthopedic surgeon, and unfortunately sometimes with a physiotherapist, is that a sports medicine physician, he integrates, he balances, he synergizes a musculoskeletal functioning vis-a-vis your sports techniques, your sports training technique patterns, and keeps them in synergy so that you don't have an injury, yet enhance the performance. So that is what is actual sports medicine physician working on musculoskeletal injuries examination. And for that, you need to know your biomechanics. You need to know the mechanism of injury, because identifying a biomechanical risk factor which will eliminate the groin pain. In this, I must give a word of thanks to Dr. Ashok Ahuja, who, when the first time I went to him with a case when NIS Patiala 1998, I told him, sir, this is the injury and this is the diagnosis. He asked me, what is the mechanism of injury? He said, in sports medicine, if you don't know the mechanism of injury or how did the injury or what is the injury, how it happened, you will never be a good sports medicine physician, because your thing is not only to treat the injury, you have to prevent the injury and make this athlete get better in having not getting an injury in the future. So your assessment of your, which we did till now, should focus on pelvic symmetry, that is the core stability, leg length inequality, which could be anatomical or functional. You need to identify it. You have to see the footwear. You have to look for the malicious misalignment syndrome of knock knees, foot pronation, external rotation. These all can contribute to your groin injury. So for my dear friends of sports medicine, if you're just going to dig into an adductor or dig into the pubic, you're not doing your proper assessment. Your assessment has to have these four things in mind: pelvic asymmetry, leg length, footwear, and looking for these malalignments, misalignments. So most move the intrinsic. So again, please do not get me wrong. I'm not trying to be big. I find sports medicine fascinating because, unlike other specialties, you know that what is the cause of an injury. It's how I oversimplify it is internal factors. I think most of us should be doing it or are already doing it. Is external factors. Internal factors is look for all misalignments and all, and external factors are too much, too soon, too fast, too poor. All your training loads, what surfaces, what shoe, what dietary pattern, your external factors. You get these two things, you solve most of the problems. I won't say all the problems, but most of the problems. So most of the common factors like foot alignment, knee position, tibial angle, anteversion, leg length discrepancy, and a past history of injury. You have to have a well-balanced pelvis, and like I stressed on the sacroiliac joint, so well-balanced pelvis is essential, which requires the coordination of different muscle groups. We'll speak about what do you mean by well-balanced pelvis. SI joints at the back of the pelvis and pubic symphysis at the front. They should form a unit when you're moving. If the pelvic girdle is not balanced and firmly tied by all the ligament and structures, it cannot effectively allow movement of the legs without excessive strain on the pubic symphysis joint. Pubic symphysis joint may shear or separate, causing pain. So look for faulty foot mechanics, gait disturbance, poor running mechanics, tight, poor hip range of motion due to muscle stiffness in the hips, groin and buttocks, muscular imbalances, and leg length differences. So don't become uh, a sports medicine physiotherapist by only doing prescribing ultrasound, lasers, and all that. Look for the causes, find out the reasons, start fixing them, start correcting them by identifying those structures. What happens in a malicious, so you have an unbalanced running stride, the adductor muscles tend to tighten, you have a limited external rotation, tightening of iliopsoas, and you develop an anterior pelvic tilt. These are all biomechanics which you're seeing, resulting in an increased spinal curvature, tension in the lower back, and muscular system to function unnaturally again. This results in weakening and micro instability at the osteochondral junction, and then you have pain and eventually an injury. So again, a little bit of the malicious misalignment. We look for all these things. Now, you would ask me that, okay, we got all this. What do we do with it? So sports medicine, like we all know, is a multidisciplinary specialty. You have to involve foot orthotics. You have to involve insoles. You must also use podiatry at most times when you can't fix certain foot pathology. So this is an important reason. What are the investigations in groin pain? We have the flamingo view, which is of the to see the alignments. If there's a misalignment which is causing besides the MRIs and all, which we already know, this is something called as a flamingo view of the X-ray, where we can see the height of the femur, which area is the SI, so we can velvet it into deeper. So when you do a flamingo view, and even if you get a 2 mm difference, you know it's going to contribute to these things. A word about femoral length discrepancy. There are various studies which were done, and they saw that a 5 to 15 mm difference might be normal. Some felt 20 mm difference would be normal. So what I would call the anatomical structural correction only to be done when you rule out the functional reasons contributing to this anatomical length discrepancy. And if it is a true one, then you go in for your heel raises, foot insoles, etc. So MRIs, the grade 0 injuries, 1, 2, 3. I attended this talk of Aspetar. They don't give great credence to the MRI as the way of deciding your rehab. They base it more on classifying an injury, but treatment is based on repeated examination. So this is what our adductor longus rupture looks like. See, the one is at the pubic tubercle, and 2 is the disruption of the adductor. Ultrasound for various conditions, and rehab. Now, this is something very interesting. So for those, when you get these cases, so you have two types. You have a TOPER, a topper, or you have a UNDRS, unrest. So if you have a TOPR injury, that is traumatic, it is on one side of the pelvis, you have positive clinical findings and eccentric overload causing the injury, your rehab is going to work. You will be successful in your rehab, provided you know your rehab and you know what to do. However, if it is an unknown insidious onset, negative findings, diffuse pain, both sides of the pelvis, you've rehabbed him not very successfully, he might require one of the surgical treatments like a release or a inguinal ligament release or a transverse abdominis or maybe an adductor. Something else would be required. So remember, if you have a traumatic one-sided pelvis, positive findings, eccentric overload causing, rehab is definitely going to work, whereas these might not work out. So what's my take-home message for all my friends from the world of sports medicine? So first and foremost, minimize pre-existing risk factors and compensatory strategies. That is by doing screening for off-season. Those of you who are with teams, commence a global strengthening program. Adductor does not mean you fixate on adductors or that muscle group only. Early loading for tissue regulation and pain reduction. I said, do not wait only that I will use physiotherapy till the pain vanishes and then begin with my exercise program. Begin isometrics. It can regulate and reduce the pain. Progress to dynamic loading, must progress. See the Holmich Protocol, which I talked to you about the first 2 weeks, and the next module, which can go up to 18.5 weeks. Progress, integrate dynamic loading, introduce speed. I showed you an algorithm how to check whether it's okay, and then do a speed. What I do is I do a walk jog program for 4 weeks. That is walk for 3 minutes, jog for 2 minutes, then for 20 minutes. So 3, 2, 3, 2, then walk for 2 minutes, jog for 3 minutes, then make it jog for 4 minutes, walk for 1 minute. And then I introduce short sprints. I tell them to do it on alternate days, short sprints, then figure of 8 runs, then agility drill. So keep doing this speed. So try to progress, be within the range of 0 to 4 in your VAS scales when you're doing it. No pain during exercises, only for your pubic symphysis, because don't tug on it, especially in kids, adolescents. It fuses at 20. Remember that. Treat it as an apophysitis. Respect pain post-exercise. Facilitate the abdominals, adductors, and stabilizers. Improve the lumbopelvic stability, first by examining and then working on those muscle groups. Work on total hip strength. Even if you get a OA knee, work on the hips, work on the hip strength, work on the glutes. Don't fixate on quadriceps strengthening or hamstring strengthening. You have to work on your hip. It's a very, very important method of rehab. Regain effective muscle strength without stressing the pubic symphysis. Maximize the range of motion in the hips, internal and external rotators. Gradual progression based on objective functional and clinical markers. Objective criteria is required for return to play. Maintain adequate fitness by cross training. Very important. There is for every 1 day we rest, we get detrained by 3 days. Commence a single length stance proprioceptive and strengthening. I cannot pay more emphasis than this, that proprioceptive training and perturbation training should be something which all of us should read. We should all adapt. Proprioceptive training for the upper limb, what are the proprioceptive training, and for the lower limb is a force multiplier in your rehab programs. Trust me, do a proprioceptive training, you'll see most of the cases which are not improving will start improving. I reevaluate and I would recommend a reevaluation every 2 weeks. Time frame to consider for surgery: minimum 12 weeks of specialist groin rehab. Remember the protocol which I mentioned, not the protocol, the recommendations of TOPR and UNDRS. If it's a sportsman and you feel 12 weeks is not doable, take a decision by 4 to 6 weeks. Thank you. I once again thank you all. I was told 40 minutes, but I've done it in 1 hour 10 minutes, and so I thank you very deeply for the patience. Thank you very much.